So I think we can start. Ladies and gentlemen, you're most welcome once again to this very interesting webinar. And this is one of a series of them that we are hoping to have in the coming weeks. So our program structure today will be, I'll start with, we are going to start with listening into our panelists. We shall start with Leah. And then after Leah has presented in 7 minutes, we shall have a 3 minutes reaction to her presentation from you, the participants. And then we shall have Naomi. Naomi will also do the same. Naomi will also do the same. And then we shall also have, after Naomi, we shall have Dr. Obed, who will also have 7 minutes as our panelists. And then after we have had Dr. Obed, we shall have reactions from one of our experts to give a bit of remarks on coloniality in Africa, and then we shall conclude with Dr. Danny Goto with the perspective of coloniality, development assistance for health and its impact on Uganda's health system as the guinea pig. But he will address all aspects that are existing in Africa. And then after that, we shall have a 15 minutes discussion or Q&A. You could either ask a question to the panelists or you could react to something that the panelists said. And then after that, we shall have the concluding remarks from the panelists, either answering questions or making additions to their submissions. We are hoping to end this by 3. And I hope if we keep time, and I hope we shall all keep time. So at this juncture, allow me to introduce Leah. I don't know whether Leah is on the call.
Hi, Dennis. Thank you. Yes, I am. I'm here.
Yes. So briefly, who is Leah? Just a minute. So I want to briefly tell you about Leah before she starts making this presentation. So Leah has a very interesting area of work. She is the Deputy Director of Development Reimagined. And this is an organization that basically it's a development, it's an international development consultancy which is based in Beijing. And it has offices in Kenya and also the United Kingdom. So prior to Leah working with as the Deputy Director of Development Reimagined, Leah worked with the UNDP in China, supporting UN portfolio on Southern Cooperation and the Belt and Radio Initiative. And before she again lived and worked in Kenya, to develop sustainable development water policies for the government. And then also Leah has lived in China for 9 years and has traveled extremely around Asia and Africa. So as you can see, she's working in a very interesting sector. And we'll begin with her to give us a perspective on coloniality where China is concerned. And I would expect the audience really to react with questions and probably additions to what she has to say, because we all know that China is perceived as the new upcoming colonial master in Africa with lots of interests. And so we are saying that as Africans, to avoid this issue of unbalanced coloniality, we want to be partners, not just a give and take. So Leah, please, you're welcome. I will give you 7 minutes. Please rush through your presentation. Would you want me to, are you going to share your screen or would you want me to?
I don't mind. Can you share the screen if you have it to hand? Thank you, Dennis. I'm just, I hope everyone doesn't mind. I'm just going to turn my camera off while I'm presenting, just because the internet can be a little bit unstable. So yeah, good evening from Beijing, everyone. Thanks again, Dennis, for the warm introduction. So just to reiterate, my name is Leah Lynch. I'm the Deputy Director at Development Reimagined. So again, let me just very, very briefly introduce the organisation. So as mentioned, we're an international development consultancy. We have our headquarters here in China. But I think what's really exciting about the organisation is actually we're the first Kenyan-owned company in Beijing, and one of very few with a specialism on China-Africa relations. And in this, we're really, trying to drive African agency in the relationship and change some of the narratives around this space. So it really is an honour to join this, African-driven discussion today. So a big thank you to the organisers, and I'm really looking forward to learning a lot from everyone. So I'm going to be sharing kind of the work that Development Reimagined has been doing in this space, particularly drawing on a piece of work that we've just published called Forming a Coalition of the Willing to Decolonize Global Health in Africa, which you can see on the screen. And please do feel free to reach out. We've got my email on there and also the website. So just to mention, we don't have an office in Uganda, but we do have an office in Kenya. So I hope kind of the information I'm going to be sharing is more bigger picture ideas, but it can definitely be adapted for the Ugandan context. And I'll try and bring in China a little bit into it. So the report, which you can see on the screen, I really hope everyone will have a chance to go and read it after this webinar. I'll share it in the group chat. And essentially what we were really trying to do with this piece of work was look at the actions that can be taken by global health organizations to decolonize global health, in particular in Africa. And I mean, the stimulus for this project and the subsequent research we've been doing has really been driven by COVID-19. And essentially the kind of this narrative of expected failure in terms of how low-income countries have responded to COVID-19. So let me explain a little bit what I mean by that. So at Development Reimagined, we've been tracking COVID-19 literally from the very beginning, from March 2020. And a lot of the narratives that have been coming out of kind of higher income or developed countries was, oh, I think I just got accidentally muted. Yeah, so a lot of the narrative that was coming out of higher income countries was around a lack of ability to respond, economic crisis, and this was often just incorrect and very, very racist. What we were tracking was that many African countries were taking fast and decisive action. They were providing good economic packages, they were closing borders, they were implementing social distancing, and this was often very, very overlooked. And now as we kind of move on to the drive to vaccinate everyone, we're seeing this narrative again. We've been continuing to track COVID-19, and actually our most recent piece of work is found that African countries only have less than 2% of the global vaccine supply, and only about 1.2% of Africa's population is currently vaccinated. So this was really all context for why we wanted to start this project, as well as our specialism on China-Africa. But we really wanted to, explore some practical examples of what the challenges are for implementing, health projects in Africa, but more importantly, what actions, if any, are these global health organizations really taking in practical terms to decolonize? So, ultimately, the report does aim to inform global health organizations of what needs to change and how. But I think for this conversation, and what I really want to note is it can also be a really good advocacy tool for civil society and other stakeholders, to hold global health organizations and to also hold governments to account and say, you need to change, and this is some of the ways you can. So you'll see on the screen now, it's a little bit of information about what we actually did on this. So firstly, to collect some really concrete examples, we conducted a survey that was shared widely through networks and on social media. I think we had about 70 responses or so. And I actually know some individuals on this call participated in the survey, and we're really, really thankful for the input, because it really was invaluable to hear exactly what's happening on the ground in places like Uganda and to really feed this into the report. So we also hosted a number of dialogues, which you'll also see on the screen there. And that was with a mixture of local organizations and global health organizations to both discuss the challenges, but really important to try and think of ways forward. Dennis, could you put the next slide on, please? Okay, so through the survey and dialogues, we essentially found 5 key themes that ultimately created a framework for the next steps of how you can dismantle these colonial structures that have been put in place by these global health organizations. Now, we don't have a lot of time today to really go into lots of detail on this, so I'm just going to look at one theme in particular, what kind of links into finance, and that's procurement. So essentially what needs to change in procurement, because this is often an area that's really, really overlooked, but is very, very important. So can we have the next slide, please? Okay, so although there has been significant investment and progress, made by many countries towards the SDGs, there's actually been very little improvement in access to essential medicines and medical supplies. And this is really due to outdated procurement and supply chain structures. Now you'll see on the screen, when we did our survey, we found that around 30% of all procurement funds were coming from charity, and then another 40% was from bilateral donors and multilateral donors. So that means that a really tiny amount was actually being mobilized locally. And why that's really important is because this means local organizations are tied to the procurement structures of these global health organizations, which are often very centralized. And the limitations of that have, really been seen during COVID-19, where, access to essential PPE and vaccines has really been limited due to these global procurement practices. I'm sure many of you have faced these issues yourselves. And in the dialogue, actually, someone shared a really interesting example. So this was an organization working in Peru, actually. And I didn't know this, and I thought it was very interesting that Peru was only one of just 5 countries in the world that has a really specific electrical current. And of course, due to the pandemic, a shortage of oxygen and the need for ventilators. But because of a lack of perceived profit in the past, there's only 4 manufacturers in the entire world who are producing ventilators that can be used in Peru. This meant a huge shortage for all of the organizations who were working on this, for the hospitals, for the governments, and they were all tied to these global procurement practices to be able to get this life-saving equipment. So through the dialogues, we really saw that what needs to happen is that organizations need to start and evolve their decision-making on procurement, make it more locally owned, but decolonization of procurement really can go a lot further than that. And what we really want to emphasize is that organizations need to be ensuring sufficient incentives for local manufacturing to kind of avoid these situations like you're seeing in Peru. And also with the vaccine supplies we see now, where local manufacturing is really important. We did a lot of research to try and find some organizations who were working on this, and one that really stood out was UNAIDS, and this is where China comes into this a bit. So this was actually back in 2018, so before the pandemic. They did some research into Chinese pharmaceutical investment, and they looked at 21 African countries. They found that all 21 countries were importing these Chinese health products, which was including traditional medicine, Chinese traditional medicine, and that the top 3 importers, South Africa, Egypt, and Nigeria, were actually importing over 300 million USD each a year, which is a really, really high amount and shows such a reliance on China for these drugs. So what UNAIDS were trying to do was say, let's change this reliance on the drugs from China, and instead say, let's drive Chinese investment into local manufacturing on the African continent. And the way they were doing this was by educating Chinese stakeholders and also trying to work with the Chinese government to try and find incentives for this. And we ourselves, we have seen appetite to do this, but this started in 2018, investment is still very slow, and there's a lot more that can be done. I've actually put a quote in there from a Chinese investor that's working in Africa, And they said to us they're facing lots of difficulties in regards to trying to channel this financing. So this is something UNAIDS is trying to work on. And I think more in just broader terms, just to bring it a little bit back to the report, we kind of give 3 major suggestions when it came to procurement, which I'd just like to briefly mention. So firstly, as I've said, it's so important that global health organizations are exploring local manufacturing. You need to improve partnerships to curb this crazy bureaucracy and provide the incentives, as I said. Secondly, invest in local research and development. So, looking at trying to avoid IP barriers, but also about retaining talent, which also links to another theme that we had, which I won't go into, but it's in the report, which I'll share. And then thirdly, also investing in the technology sharing, because self-sufficiency really is key for a robust health system, but you need the technology in country, which again, links to the procurement practices. Now, in regards to next steps for this specific project, when we're looking at the Coalition of the Willing, we're working with the United Nations University in Wilton Park, and we want to try and get as many organisations as possible involved in this coalition to drive it forward. So please do reach out if you're interested. We do want to make this coalition a reality. And Dennis, if I can have 1 more minute, I just very, very briefly wanted to mention China again. If you can go on the next slide, I will not take long.
Yes.
The final slide. So basically, just to explain a little bit about, because I haven't spoken a lot about China, but I think it's going to come up, exactly what we're trying to do in regards to the China-Africa relationship. So we're really trying to work on providing lots of data-driven research to understand the current status of what's going on. So what's happening with trade or capital flows or people-to-people flows. And this includes health, such as say medical teams or Chinese aid or Chinese investment into medical infrastructure. But our ultimate aim as an organization is to try and provide some clarity on this relationship, because both policymakers and civil society, there's not a lot of information on China. There's a lot of things that are misunderstood. So we're trying to put as much information out there as we can, so people can understand what's happening. And we spend a lot of time working with African stakeholders to, really try and increase African agency. We're completely African-led organization. CEO is from Kenya. And we work to try and provide, recommendations on, how best to engage with China, how best to negotiate loans, how best to channel foreign aid, and how to make the relationship more balanced, which is really important. So I will stop now because I know my time is up. I just want to say a huge thank you to everyone. Welcome any questions and look forward to hearing from everyone else. Thank you, Dennis.
Thank you, Leah, for that very interesting discussion. So we have a few minutes open for you, the participants, to either make reactions, questions, so that we move on to the next panelist. Any questions? You can raise your hand.
I've just shared the report in the chat, but I'll put my email, feel free to reach out. I'm also going to share one other article that might be really interesting for everyone to read, which is actually looking at, is China a colonizer? So I'll share that in the chat too.
Thank you.
Dennis, Danny here. I think one of the things that I want Leah to make a mention about is the relationship that we see between development financing from China that is totally, a little bit not different from the old Western development financing, where, for instance, if aid is coming from China, it comes along with Chinese. If it is to build a hospital, China has to bring its labor. It doesn't build capacity. It doesn't really build local content, and it takes back. We also see this in extractives, in road construction. What do you have to say there in terms of data or any research done in tracking participation of Africa or Africans in development using Chinese grants, but also the cost of loans from China is a bit parasitic in a way that it is high interest, short term, and it is not the answer to Africa's development challenges, especially in health, now that we need more money during COVID situation.
Okay, I think that's a really, really good question. Thank you, Danny. And I think this is partly why, as an organization, we're really trying to provide as much information on this as possible. And I think something important to understand is China is not just one actor. You have lots of actors in China, just like you do in lots of countries. So you have both the government, which can be providing loans or providing aid, but you also have the private sector, and private sector is obviously driven by its own agenda, and you've got to bear that in mind when it engages in cooperation across the continent. It is profit driven like any other private entity. Now, in regards to the research we've been doing on conditions when things come to providing foreign aid or loans, we've actually found that conditions are normally a lot less, and China is learning quite quickly. So, for example, in regards to local labour, I think it's a little bit misunderstood that there's always lots of Chinese workers, and a lot of it depends on the country and the pressure that's put on by the local government. So particularly in countries we've seen where there's really strong labour laws, it doesn't actually stop China from engaging with that country. They will follow that law and they'll have more local employees. And I've visited some sites myself, and I've kind of seen how they will try and employ as many local workers as they can, but there is a lot of work that still needs to be done on that. In regards to loans, it's very nuanced. There's lots of different answers to that, and every country is a little bit different in regards to what's happening. I can certainly share another really interesting report on this, which we actually tracked the kind of debt flows of African countries and looked at China as is it a major creditor, and then how does that compare to other countries. And actually, in general, China lends less money than, say, you see from Eurobonds or other private lenders, but it does, as a bilateral lender, normally give more loans. So I think you can look at it from lots of different angles, and I'm not here to defend China. I'm just here to say that there needs to be more information out there, which is what I was saying, and that's why we're really trying to provide that information so everyone can understand the whole picture and say, you know, is it just that there's a lot of Chinese workers, or is that just a misconception? Can we see the data? I hope that helps a little bit to just clarify without taking too long.
Thank you, Leah. It's been a pleasure to have your
of that. The G2H2 is poised, and we present it to you for your consideration and adoption, is poised to build a space, you know, for both discussion, build a space for discussion, and at the same time boldly advocate, you know, for a number of clearly spelled out issues.
Thank you. Can we have Ravi? Ravi, please unmute yourself.
Yes, thank you, Dennis, and thanks, Leah. Good to have this presentation. I do know that time is short. We want to hear from other speakers, but I know, Leah, you may be stepping away from the call at some point. So I wanted to bring one question to you. And there's been a question already from Danny about the China-Africa relationship, and that is a live question. Let's ask about Development Reimagined itself. My understanding, and perhaps with others, it's a private sector consulting firm. And you've also got this parallel initiative looking at civil society. That's a model that's been well walked by many other Western firms. And we could cite some from the UK, US, across Europe. So I'm wondering, in what way, apart from being based in China, as opposed to being based in Europe or North America, what actually distinguishes Development Reimagined from those other firms? And along with that, how, given that Chinese independent critical civil society is quite weak to the extent it exists at all. How would China add any value at all in terms of civil society discussions and critiques about power relations?
Thank you, Eric. Again, that's a really, really good question. And we are a consultancy, but just to mention, we're not like a massive profit-driven consultancy, you know, like McKinsey, where we're really trying to make lots of money from the work that we're doing. All of our backgrounds are from the UN, and what we're really trying to do is, work on development work. And a lot of the way we do our funding is we will drive it into other projects, and we work a lot with the UN and big organizations. So we're also trying to influence them as well. The decision to have a headquarters in China was taken by our CEO. So aside from myself, all of management are Kenyan, and we're really trying to bring this African perspective into China, but also support both African policymakers in China and also Chinese civil society to understand a little bit more about Africa, because there's still a lot of a misunderstanding. So we have, Chinese team, we have a very, very diverse team from about 23 countries actually. And we're really trying to bring everyone's perspectives together. I'm just one person who brings my experience, and I just happen to live on China on that, but we're just trying to dismantle some of the existing structures in regards to how a consultancy would work. So for example, most of our projects, if we have, if they're based in Africa, we'd have an African consultant working on it. We're trying not to think in the same mindset as that other organizations thinking, which you'd see a lot of in COVID, and it links back into decolonization. Instead of flying a consultant to Senegal to do a piece of work, we'd make sure that someone in Senegal was doing the work, they're credited for it, they're the lead author, they drive the research, they drive the methodology, and it's about them. So we do try and practice what we preach in our own organization. It's just, it can be a complex model when you're in China. Now, I don't know if I've answered that completely well enough for you, Ravi, but I'm happy to kind of talk a little bit more with you about it offline when we have more time.
Thank you, Leah. We have given a little bit of time to Leah because she'll be leaving us shortly. She won't end the discussion, so she won't have the chance to really do the concluding remarks. So the others, please, you're not going to be given more than the minutes allocated. So at this juncture, please allow me to invite Naomi Tulai Solanke from CHI in Liberia. Naomi is going to introduce us to the coloniality in maternal and newborn child health in Liberia and the strategies to decolonize it. Naomi? Is Naomi with us? Naomi?
No, Dennis, I don't think I can see Naomi. If she's not, probably we could go to the next presenter.
Okay. So I think we shall skip Naomi for now. We shall bring her on when she joins us. So allow me right now to move on to the next presenter, and that will be okay. Okay, that will be Dr. Obed. So before I invite Dr. Obed, I just wanted to give a brief background about Dr. Obed. Dr. Obed Kabanda is a dynamic public health non-profit and social justice leader that is with 17 years of expertise in NGO management, partnerships, fund development and management, and donor relations, as well as champion grassroots voices in fields of international development, public health, and human rights. And with 15 years as the executive director of ACODE. Currently, Dr. Obed is serving as the interim chief of party, International Fund for Grassroots Organizations, And, he is also a graduate researcher at the University of Seattle. Dr. Bed has been leading the processes of developing the funds, systems and structures. And his mission has been advocating for systems change in philanthropy and funding. Finally, I think Dr. Bed holds a university, a Seattle University doctorate of organizational learning and leadership, and a Stanford Business School nonprofit executive leadership certification, and a Master's of Public Health Leadership and Bachelor of Community Leadership and Development. Dr. Bed is going to be presenting to us about, he's going to basically look at decolonizing the global health. And this one, he's basically going to give it a perspective of the international funding for the grassroots organizations. So Dr. Bed, please, you're most welcome, and we are looking forward to your presentation. Would you want to share your screen, or would you rather I share it for you?
I'm going to share my presentation, that's fine.
Okay, Doctor.
Okay, thank you. It's wonderful being with everyone this afternoon in East Africa. It's morning here, it's 4 a.m. in the US where I am. And so, you know, I'm very happy to be part of this meeting today. And more specifically, after Leah's presentation, having been able to speak about the different perspectives of changes that are going on within the sector of decolonizing global aid. I'm not sure if you're able to see my screen right now.
We can see your screen, Doctor.
Okay, great, sounds good. Going to do this. So I'm, you know, like already introduced, I'll be talking a little more about decolonizing global health aid, and specifically in respect to how do we surely make sure that aid is decolonized in perspectives of assuring that local communities and frontline workers are looking at being in charge and taking on the power. Now, I must say I'm beginning with a slide which one person from Nigeria said, "I'm fed up with being on the menu. I want a seat at the table," because this is the challenge that quite often people have remained taking lead of global health aid, and others just remaining, you know, on the menu without being at the table. And I think this is where the challenge is, and it's the driving force. Now, I want to say, based on, you know, building on what Leah just mentioned, and I thought that Naomi will have already shared her perspectives, but I wanted to say decolonizing aid is a big debate going on right now. It's a complex matter, and we cannot just look on. One of the things I wanted to emphasize is the fact that decolonization involves a lot of reimagining and rewriting the global health narrative, but also, especially in the era where we are seeing serious, complex global health challenges like the COVID-19 pandemic, which indicates totally different perspectives, which presents different power centers of, you know, you've seen vaccines being accessed by a few countries who are hoarding, and, you know, many situations that are going on within the parameters of COVID-19. So such global health challenges are beginning to, I keep saying that if people cannot see what is going on in the world right now and reimagine, but also rewrite the global health narrative, knowing that we are now in a global village, and one person who is, you know, sick or having a challenge in India or in Zambia will affect someone who is globally here in the US or in Latin America or wherever. And so we must do something that is bringing perspectives of people being together in a global village. In decolonizing aid, I must say, it's going to take devolving power. Leah already talked about this, and I want to say there's issues of power, there's issues of privilege, there's also issues of decision making. You'll believe with me and say the issue of decision making and the challenging of negative systemic narratives as they relate to global health perspective remains. And I think this is one of the biggest challenges that each one of us have to begin to think about as we continue to see the negative systemic narratives that are going on. It will also entail dismantling disproportionate global health financing, quite often that favor the few, but also not focused on building local capacity, but instead looking at profits. Already Leah mentioned this, I hadn't even seen her presentation, but you find most of the, like she talked about China and all these other companies who bring in medicines or who want to bring in pharmaceuticals, you'll find people are only focused on profit making, but not necessarily looking at financing that is, guaranteed to help relieve people from the challenges. I'm also saying, I think decolonizing aid will take intentional and authentic leveling of ground. If partners globally cannot see the need for intentionality and authenticity in leveling ground for equitable global health practice, it doesn't mean that people are not doing much, but I think people need to be intentional. Global health actors need to be intentional. Bilateral agencies need to be intentional in supporting research, in supporting local innovation, in supporting publications. I think we are tired, with situations where people come do research and the frontline communities cannot even know what has happened with the research, cannot even know what has happened with the research outcomes. I think this must stop, and I think it will take that intentionality by most global health actors to know that there is need for this leveling. It will also require outright acceptance by global health actors to create space for local innovation and allowing vulnerability for loss of power. One of the challenges we have right now in decolonizing aid is most of the people who own power, who own privilege, to managing resources, do not want to develop this power. They do not want to give this power to the frontline workers. And I think that's where the challenge is. We must begin to know that there is need to shift thinking, to shift aspects of creating space and making sure that people can be able to have opportunities to challenge power centers. Now, specifically, what are we doing in the work of localizing the problem of global health? In the fund which I'm managing, which is International Fund for Grassroots Organization, the model we believe in is that the best global health development, but also solutions, come from locals, and localized aid is essential to development, but also that the majority of resources are still top down. And I think this is where the challenge is. Funders are not designed to reach the grassroots. It's like electricity being generated and going straight to the power consumers without being transformed through transformers. And this is a huge challenge. It can burn the end users. So we need intermediaries. We need intermediary supportive mechanisms for ensuring that aid can be designed to support grassroots. One of the things we have done with the fund, and which the fund is based on, is that majority of the funding still is being directed to select few international NGOs. And I think this is a challenge for global health aid, because then decisions are still, for the most part, being made behind closed doors. The fund we are managing is basically acting as a direct link between grassroots, but also philanthropists and donors. And the focus is on Sub-Saharan Africa with the potential to expand globally. Our vision is, making sure that we are seeing a systemic change in philanthropy and funding for global health that leads to a more balanced and accountable approach to development in direct partnerships with impactful grassroots organizations globally, but also leveraging power systems of working together, amplifying impact, and supporting local solutions. One of the ways we do this is to drive more respectful and impactful grants directly to local social change efforts managed by grassroots, and making sure that we work with everyone locally. Because if we can't have global health actors believing in local actors and funding providing funding directly to people who are frontline workers in alleviating hunger, disease, suffering, and all these other human rights abuses, we are not going to see changes. So that's the work we are doing, and I believe that together we can make changes if we can demand accountability for changes within the systemic barriers that are impacting on global health. So I want to stop it at that. We will have more moments to and questions to answer in respect to this. Thank you.
Thank you so much, Dr. Obed. So back to you, audience. Please, you have a few minutes to speak to Dr. Obed, either make reactions, questions, any additions or subtractions, please. You're most welcome.
I can see there's already a question from Ravi about speaking more about the decision making about that funding. One of the challenges, like I earlier highlighted, is that power centers for decision making for people to determine who gets the funding, I think, has been a challenge. This fund works in such a way that even the advisory board is comprised of people who are from the grassroots organizations, and there's no power. There's no issues of someone taking charge of determining who must get how much money, or defining objectives for the fund, or how the fund is going to work. So there is collaborative funding. There's respectful grant making that builds on the needs of the people, that builds on the local context of the frontline workers, determining what exactly they need, and being able to have a restricted funding that should be able to support the needs that focus on local challenges.
Okay, can we have Job?
Yes, thank you.
Please.
Thank you very much. This is Komakech Job. My question to the good doctor is, how can an NGO locally raise funds without necessarily being seen as making a profit in order to do its work? Thank you.
Thank you, Job. That's a very wonderful question. I think.
Can we, sorry, Doctor, let me first take another two questions, and then you can answer them at once in the interest of time, if that's okay, Doctor.
Thank you. That's
okay,
fine.
George, can we have George, please?
Yes, thank you, Comrade. And Doc, thank you for this presentation. We're talking about support to grassroots organizations. I was just thinking, how can this be achieved when donors usually have targeted projects that they have in mind, especially so in the health sector, where we see this kind of horizontal and vertical funding so far. How can we make local players come into the play when donors or people who have the funding have different things in their mind, or they have a different mindset? Thank you.
Thank you, George. Can we have Edward Sally? Edward, please.
Thank you, Dr. Obed, for that good insight. My question is about how you're harnessing the capacity of community health workers. Are you working with them and building their capacity to enable you get feedback from the communities that are being served by the organizations at the grassroots?
I will take one more question, Doctor, and then we proceed. You can proceed to answer. Chris? Chris, please, you can unmute yourself and say something. Okay, I think we have lost Chris. Can proceed with answering those few questions.
Hello.
Chris, go ahead.
Chris, go ahead.
Yes,
thank
you so much. Yeah, thank you so much, Dr. Bed. My question is, of course, also come with a comment, looking at why resources should be directed where there is the biggest need. I mean, be proportionate to the needs. I'll take an example of the current pandemic that is hurting the world. But coming back to Uganda, where I arrived from, all know that COVID-19 is ravaging Maori people who are living with chronic ailments, especially the non-communicable diseases. But when you look at all the resources, nobody seems to wanting to think that communicable, non-communicable diseases should be thought about, and there is no single resource that has been directed to that sector. And also that non-communicable diseases in my country are responsible for over 30% of all deaths and all ailments. But when you look at the budgeting and the resources, there is nothing that talks about that. So we think that resources are not, put in line with the, are not, allocated proportionately to the burden of the problem. So when you look at the health financing, I think there is a need at the highest level possible to rethink and rechannel resources where they are directly needed. Thank you.
Okay, thank you, Doctor. Please proceed to answer, and then we can.
No, thank you, Dennis, and thanks to the members. These are very wonderful questions. I wish we had more time, and I'll try to answer most of them. First of all, I think I want to make a comment about how different is this model that we are looking at in championing grassroots change, social change that is, championed by the local population, by the local grassroots change makers, other than just receiving grant aid from the North. I think one of the issues I want to say is that we must believe and know that local solutions, grassroots-based organizations, frontline workers like my brother Sally has just said, the health workers, the frontline workers, the frontline women and men who are trying to do something, young people, youth organizations, based in rural Zambia, in rural Zimbabwe, all these people are doing something very important. And they must be supported to challenge or to be able to do the work they are doing effectively without restrictions, without being told what to do. Like my brother was talking about donors, George, I think, having targeted projects. One of the challenges I must say is that grassroots organizations, we've been at the table, but not controlling anything. Issues of decisions, issues of determining how much money comes to us, issues of determining, even what kind of goals, what projects, what type of numbers we are going to be collecting within the global health sector. All these are being defined by global health actors or donors who do not even know what is happening on the ground. And this is the basis for this fund. Even if I'm in Seattle right now, the issue is that I am a Ugandan, I am based in Seattle. I came to do my doctorate. I'm done with it. I'm coming back to Africa. The point is we need to take charge of our own development. We have resources on the continent. We are saying we must even challenge leaders, local leaders, political leaders in Africa to begin to look at development aid beyond just supporting programs or building hospitals for political ambitions, but for rural social change, because this is where the issue is. We have corporates like MTN, mobile telecommunications, which are having lots of money. We need to demand corporate support for projects that are based on the continent and decolonizing aid. So back to specifics, I think from George's point of view, I think not George, funding versus non-profit, the more you are well defined with your vision as an organization, to know that you are an organization which is doing work that is meaningful to the social change of communities. I think profit, there is no way you're going to be looked at as making profit when actually you're following your mission. So it depends on the mission and the modality, the social change, the theory of change you are using to do your work as an organization. The issue of donors being the ones to determine, projects, I must say I challenge that. This fund challenges that, and I've spoken this at USAID meetings. I keep saying there is no way you can sit in Washington, D.C. and begin to determine what's going to happen in Zambia, in Zimbabwe. We must be the ones to drive development. We must be the ones to tell people what they need to measure, because whose change are you measuring? Whose evaluation are you doing? When people locally cannot be able to determine what their change looks like. So we must move away from this narrative of, we want these changes to happen. We must be the ones to tell people and say, we need these changes to happen. We need these monies to be able to do this change, not being directed what to be done. I think that's where the issue is, and we must stand strong on that. And this is why the voice of the grassroots fund comes in, because when we are disoriented, when we are working in silos as organizations, there is no way we are going to have a bigger voice to demand together. And the fund creates a mechanism, not just collecting money, like my brother has just asked here, you know, that how different is this from collecting money from the global? It's not about collecting money, it's about a voice, using research to say we are grassroots, we know what grassroots and global health needs are on the ground, and we need to direct you with, and this is why I keep saying the low middle income countries, our leaders must come out strong and be in charge, because we cannot just continue to be recipients of aid, and we cannot even demand accountability from global health actors. Receiving $100 million, you cannot just sell a country because you're receiving $100 million and you do not even know what the donors are doing in your own home, in your own country. I think this is where the issues are. We must work towards ensuring that we challenge these systems, these narratives, and it calls for joint effort. It calls for people coming together. It calls for research, local research, not research that are managed by the Stanfords of this world. It's about working together. Finally, I think working on issues of pandemic versus non-communicable, I hear you, Chris, and I must say that we must continue to demand, and that's why the fund is here to say we work together to challenge the systems and demand more funding to go to the local grassroots. Thank you so much. It seems my time is up, but we can talk about this issue more. Thank you.
Yes, thank you, Dr. Ed. And really, I would really love you to go on and on, because I know what you're tackling is such a topic. But in the interest of time, we have to cut you short, and probably if we have more questions coming in at the end where we have Q&A. But I also want to go to the dialogue box where somebody has raised something very important that I think we will have to react to again at that time of the Q&A, where I think this is Thomas, who says, not all rich international NGOs are based in global north. What about power imbalances within Africa, civil society and organizations with smart professional NGO fit for getting projects and grants? I think, please keep the questions coming in, but allow me still to go on to the next presenter, because we still have a couple of them. And then we shall come to the Q&A where you can all react to. So at this juncture, allow me to introduce another doctor, but this one is a medical doctor who loves being called a social scientist. That is Dr. Danny Goto from Innovation for Development, who is going to introduce us to coloniality. Before that, I think I'd love to hear from Ravi, make a bit of expert remarks on coloniality for us to get a bigger picture of what coloniality and the impact it has had on health in Uganda and Africa at large means. Ravi is an activist with the People's Health Movement in Kenya, and he also subscribes to the Kampala Initiative. Please, Ravi, you're most welcome. I'll give you 5 minutes for this, and then we can go on to Dr. Danny.
All right. Thanks so much, Dennis. I'll be very brief. I just want to get people a bit oriented as to where we are. And so first, a big thank you to today's speakers. I think it's been very good to hear these different perspectives. As many of you have seen, the Kampala Initiative is co-hosting this webinar series with PHM Uganda and Innovations for Development. And we're very much focused on together advancing cooperation and solidarity for health and health equity within and beyond aid. That's the main tagline that we in the Kampala Initiative have been pursuing. For those who are not already aware, the Kampala Initiative is a democratic civil society space, and we're very much involving independent civil society, critical thinkers, activists, and organizations in health to explore how we can build more solidarity-based movement around health and deconstructing the power structures that have persisted since the colonial era, which brings us to the topics for these webinar. Central to the work that we're doing is decolonizing aid, and specifically around development assistance for health. And so we've heard a few discussion points from various speakers today. We'll be continuing that with this webinar series. And the reason we're looking at this, for those who just need a bit of clarification, we see that colonialism as a political control over sovereignty, that largely ended in the 50s, 60s, until into the 70s and 80s. But coloniality has persisted because many of our independent countries have been subject to the same kind of power dynamics that persisted or that were created in the colonial era. We know that the roots of global health, or previous incarnations as international health, tropical medicine, or colonial medicine, they were implemented during the colonial era to support the colonial structures. And we've not fully extracted global health from those power dynamics. What that means is that, for instance, as has come up in the chat, we're seeing very much of top-down financing. And that's something that Dr. Obed has talked about, top-down financing for independent organizations. And that top-down financing, where money is raised in the north and then spent in the south, and through applications, some organizations are awarded funding to pursue certain activities. That very much replicates a decision-making model in which power rests in one sphere for activities, approved activities, to take place in another. So Innovations for Development, People's Health Movement, and Kampala Initiative are together looking to see how can we constructively critique the alternative models that are being developed. And let's see if we can experiment with new ideas and explore new ways of coming up with these kind of alternative models. Core to that, again, is challenging the power dynamics and seeing how we can develop alternatives for international cooperation around health. I'll close very briefly. Our first webinar in this series, it's led by the Africa group, and it's, as you see, focused on development assistance for health. We're also looking at future webinars around human resources for health, reforms to public health laws in Africa, and then also interrogating health policy and systems research as it's applied in that north-south dynamic. So with that, just a brief overview. Let me hand back to Dennis, and let's take ourselves forward. Thank you.
Thank you so much, Ravi. That was great to give us an informative perspective. And right now, allow me to again dive back into introducing another giant in the room, Dr. Danny Goto. But before Dr. Danny Goto continues with his presentation, allow me to give you a brief background about who Danny Goto is. So, sorry about that. So Danny Goto is the Ugandan, that is for the start, who has been at the forefront of advancing healthcare and for the underserved communities, and that he has done for 17 years. And not only in Uganda, but he has also been doing the same in Rwanda and the Democratic Republic of Congo. He's currently the executive director of an NGO, Innovation for Development, which again, he is also the promoter of the same. Danny Goto has again worked with partners including PATH, CRS, Save the Children, MSH, on a wide range of development programs, and those funded by USAID, DFID, SIDA, and the Irish Aid. Danny Goto has been to various institutions of higher learning, and he has an MBCHB that is from the University of Mbarara. And then he has a BEHS from Makerere University. He has an MPH from Makerere University still. And then also he has been to the Catholic University of Milan, where he got an accolade of, he got a PhD in health and gender studies. And then also he has been to the University of Cape Town. Danny Goto has served as a global activist with the People's Health Movement for so many years and still running. And so that is Danny we are having today. And he is going to present to us, he's going to present to us issues of coloniality in developmental assistance for health and its impact to health in Uganda, in Uganda's health sector financing. Because as you will see, Uganda has had that challenge that many a time the government doesn't fund enough the health systems because of its perceived well-funded developmental assistance. And yet we are trying to see that we can have a government that funds its own health sector. And that challenge we have seen today with the pandemic, that when the donors are not there, the government actually has struggled a lot. So Dr. Danny Goto, you're most welcome.
Thank you, Dennis. I please confirm that you are hearing me and you are able to see my face.
Yes,
Dennis?
I confirm you can see your face and your presentation.
Great. Firstly, I want to welcome everyone, and I thank you all for coming to join us on this important webinar. Thank you, Ravi, for that preamble. This is just one of the series of webinars that we are looking at, and we want to have as many as possible to dialogue on this matter. I'll not go into my introduction, but probably to share a little bit. Innovations for Development, we're an NGO in Uganda that is trying to disrupt development, but most importantly, put innovations at the center of the development we want. And innovations might be either in change of the way we do things, or in technology, in science, in research, but also in participation. How can we become the center of the change we desire? I'm glad to have, listened to the previous speakers, and indeed, I try to connect, but also to reduce my presentation so that I don't repeat what they shared. Now, my wake-up call in development was a couple of years back, working for a bigger grant in HIV, where we went into a household of Zephaniah. Zephaniah is a Ugandan who was struggling with some health issues. We went with a very big team of donors and implementing partners to his household. What we were doing as a project, we were trying to support them, to link them into care. So after the conversations of looking through the papers that the VHTs or CHWs had kept in their house, we left. As we were leaving, Zephaniah told me, you came here with all these so many cars to my household. You can imagine the humble household he has, the house. You've spent my entire day. I've not been to the field to work, and you're now leaving, just signing papers and leaving. Why not address my core problem, which is hunger, because I do not have enough food to eat, and you're expecting me to be able to link to health clinics to support my family in getting ARVs and stuff like that. But I was kind of held. The project that I was working on as a programmer could not allow us to spend money to do anything other than facilitating Zephaniah to go to health center, to pick the drugs that he was meant to pick, or to coordinate the community health worker who would visit regularly to see the state of health him and his family were. So with that incapacitation, no voice, nothing to change the strategy of the interventions, I was awoken to the conversation of who had the power. Which project were we doing? Was it to answer the questions or the needs of Zephaniah, or it was simply for somebody who is seated in a bigger capital somewhere in the world, who was expecting us to write reports of the people that we have reached, but not interrogating what reach and what impact it has created in their lives. So that wake-up call opened me up to the aspect of coloniality in development, and broadly in how interventions in this sector are done. I will not get into the terminologies, I will skip that. But in this perspective, the hidden power that is remaining and influencing and determining the shape and size and shift of development in our context is what we are trying to challenge. And we are saying that we need to deconstruct this power. We need to take away the superiority, the privilege, and the thought in regards to how we shape our development. Now, we took a study to assess in what context is our development assistance, especially for health, colonial. What are the evidence to depict the coloniality, and how can we decolonize? So I'll quickly get to the meat. Of course, this slide shows that Uganda has been attracting development assistance, and Africa broadly. Since the year 2000, we're seeing a slight increase in funding, particularly for health. And of course, as you know, this funding is primarily coming in the space of HIV, because HIV is significantly taking a bigger share. When we look at interrogating who is funding, there are majorly five actors. And when we interrogate on who they are giving, 33% of what they are giving is actually not coming to us. Sorry, only 33% is coming to the low-income countries, but the bigger portion of the money is going to other countries. So you would ask yourself, how come that development assistance in health, particularly coming to, which is available in the world, very little of it is coming to those who need it most. And if you take an examination of the data, you'll see that Uganda is not that high. It is primarily in Africa, Kenya, Ethiopia, and Nigeria. And of course, of recent, Ethiopia is taking lead. Nigeria is sort of regressing. So when you take it further, probably I'll skip that. The trend, we're seeing a slight increase in aid coming to Uganda specifically. I will also skip that, looking at who are the people giving. It's primarily the United States. Then, of course, we have International Development Association, UK, and the EU, and the Global Fund coming in there. So for Uganda's case, we are seeing a bigger chunk of the development assistance coming to from the United States, and much of it, which is coming to the health sector, 23% of the funding coming broadly in development is coming for health. If you interrogate further, we receive mostly bilateral assistance at 63%. Then what does it do? Of course, we know that there is the imbalance in the focus of funding, as I'll share with you later. There's some bit of cherry picking that HIV seems to be the biggest funded priority for obvious reasons sometimes, but sometimes not for the right reasons. Now, taking an examination of coloniality within the space of Uganda, we see that the development assistance that is coming into health is not cognizant of the historical injustices and the context of poverty. As people may be aware, that we still have so many people that were driven deep into poverty as a result of the land demarcation that came at the time of creation of Uganda. These people's problems have not been addressed up to today. And it is the inherent poverty they are struggling with. Now, we see that development and the aid that is coming is not cognizant of those historical injustices and supporting the country to address them. Two, the aspect of power that Obed talked about and Leah also mentioned a little bit, we see that there is less voice, especially in the funding that is coming for local actors in shaping what they want. Many development agencies send out calls for application. As most of you know, very few Ugandan civil society organizations have access to this information. It is a couple of few NGOs that bid and present their case. The focus is limited to the priority of the global health agenda, which is less informed by us as a people. Of course, the channels of delivering that aid is still colonial in a sense that it is whom you know, that you get access to resources. We have leaders of civil society locally who are saying that they think that the space is crowded by people who are not even local, or they have very less proximity to the challenges that they are trying to address. Then we are also seeing that there is a tendency for the investment being siloed in a sense that it is still disease focused. And you know, the COVID situation has exposed a very weak health system in our context. And it really, really validates the fact that aid has not been, systematic in its approach on strengthening the health system. I can give an example here. The whole of sub-Saharan Africa has no vaccine development capacity, but we have Gavi that has been spending sums of money investing in vaccines. How come that at the time of our highest need has vaccine capacity, at least to show that we can develop even the vaccines that we have been using for the last 30 years. And we think that is not supporting us. And we think that is something that we need to challenge. If people are serious in investing in Africa, they should build our systems, and our systems should be in position to help us stand on our own. Then, of course, the dependency syndrome.
Doctor, dependency syndrome, I hope you're concluding, Doctor.
Yes, comes in as a result of us feeling that there is support, and the governments become lazy in investing. And then we also saw briefly the neoliberalism that, of course, led to the defunding of health, which we are still struggling with. As I talk now, we have a very high debt burden, and our government cannot invest heavily in financing for health. So we see that because of the neoliberal pressures, which a country like Uganda needs to adhere to in order to meet the requirements for loans, it has created some imbalance and the defunding of health. I don't need to talk more about the debt trap. As I speak now, we are 51.9% of our nominal GDP, debt to GDP ratio. So meaning that for every dollar we make as income, we are paying 25% of that dollar in loans and interest. We are only investing between 6 to 7% in health. So how can we achieve universal health coverage? Then lastly, the localization of aid. As you know, aid is seemingly becoming a big enterprise, and we have gurus in aid that are the ones receiving and channeling the money to the grassroots. Of course, under the disguise of low capacity, lack of technical skills and things like that. So we think these are the elements of coloniality that need to be addressed. Dennis, I stop it at that. Probably at a later time, I'll look at what ideas that we think we could engage on in regards to decolonizing. But one of it is this that we are trying to do, is first of all trying to create awareness, trying to create empowerment of local actors to know that yes, there is something that we can do able to challenge the space. There are global opportunities. We've heard of the grand bargain, where some organizations have committed to fund 20% through local actors. It has not happened. We still see the siloism, where agencies are, channeling money, specific areas, no intersectionality, and they of course cherry pick particular areas because of their political and other interests. So Dennis, I stop it at that. I look forward for the questions.
Thank you so much, Doctor. So now the floor is open to participants to react. Ask him any questions that you think he has touched, or you could make additions, subtractions to his presentation. I think I'll give that 3 minutes, and then I'll open to the wider group. Yes, we have Hamimu, please.
Okay, thanks everyone, and thanks Danny for that wonderful presentation. I really wanted to agree with you on everything that you have said, and also wanted to touch on the example, the situation that we just found ourselves in when DFID woke up one morning and decided to do the cuts. And so the mothers and the babies who were benefiting from that kind of aid just woke up one morning and they couldn't get the, the services that they used to get. I think that is, a case of a dependency. Okay, putting all our hope and dreams into the hands of someone far away. Mine is, I just wanted to hear more about the public-private partnership and the coloniality in it. I don't know if it is there, but I just wanted to hear from you, Danny. Thank you.
Okay, thank you so much. There are some questions in the chat. Yes, the PPP model in Uganda, I'll specifically talk about Uganda. Dennis is a guru on this, has talked so much about it. As you know, in some spaces in the world, some people think that the private sector can deliver health to the last mile. As you're aware, the private sector is always seeking for profit. In a country where you still have a significant number of people earning less than $1 a day, I don't think there is any private actor who can invest in such a population. Secondly, we have also seen corruption in the private sector, especially private sector that is getting loans from external actors, where agencies are picked as foreign enterprises, and of course, because of their proximity to those that give, and they win the funding, they come to our countries and start investing in health centers or very high-end health centers, which an average Ugandan may not even afford to attend. So I think the PPP can work if it is accountable to, if the right vetting is done and the right people or organizations are selected. 3 mechanisms are put in place to ensure that it is not entirely about seeking profit, probably, but about creating opportunities for people to access services. Maybe mechanisms of repayment may reduce, for instance, where we have, like cost sharing. We used to have cost sharing in the facilities when I was a new intern, where they provide the clients will at least pay half, but not the entire, so that government meets the rest. As you know, most PPPs are loans, government guarantees under the guise that the public will pay back when they use the service. I think that model needs to be studied more. Another question is, someone asked, what role are the colonized reinforcing coloniality? I think this is true. We are not, as Africans broadly, we are not immune to the problems that befell us, even right from the start. Some amongst us are sympathizers, are beneficiaries of the power imbalance. Take an example. If you examine the amount of capital flight out of Africa every damn year, it is 10 times or more bigger than the amount of aid coming into Africa. Now, when you look at where is that money going, part of the money is, of course, from our mineral wealth, the illicit trade and the declaration of profit that is happening, or outright corruption that is happening in Africa. And who is taking it? It is the Western banks, offshore bank accounts hidden by, of course, the bigger powers. But if you examine, we have also a contribution to some of the money that is leaving. Some of the leaders in Africa are the richest. But then we're asking, why isn't our people in the global north helping us to even expose? Most of the banks in these countries are financed by money that is coming from Africa. So we are also partly responsible, but of course, we cannot negate the fact that the global powers have a role to play in decolonizing the financial institutions and creating transparency so that we also know who is stealing our money. Then someone asked did I miss Dennis? Did I miss such eventually? Is it the right time? Yes, this is a really good question. Is this the right? Are we really ready to decolonize? I think I may not have the right answer, but when I look at the current situation of COVID, as I speak now, we are in a lockdown. Out of the 46 million Ugandans, we've only been able to vaccinate 864,000 Ugandans. If you take second dose, we are at 348,000 by around there. So meaning that even if we opened up without vaccination, Ugandans are going to get sick and then we shall get into the lockdown. But just because of not having vaccines, you can say that, yes, we are inefficient, but at least the vaccines should have been there, and we are begging our government and saying, please, why are you not procuring vaccine? Secondly, South Africa is paying vaccines at a lesser price than Uganda, but South Africa has a bigger pocket than we do. Why is that imbalance there? Who is determining the prices of vaccines to make it very highly costly for poor countries and less costly for those who have more? I will not speak to the hoarding of vaccines. Some of our dear friends in the global north have done, but it has exposed that indeed nobody cares about some issue of some people. People are simply driving interest. So we are saying, can we have accountability? Can we have comradeship and solidarity? And I'm happy that very many actors in the north are joining this crusade and championing the voice and said, excuse us, we might have the money, but we cannot let people die just because we are looking inwards. So I think the struggle to decolonize is as of now, as yesterday and tomorrow, because we do not have any other choice until we develop our capacity. You saw when the president of Uganda was sharing, when he wanted to work around looking for resources, the ingredients to make our vaccines locally. Some actors in the north were telling him that for you Africans, you don't need to make vaccines. We shall make the vaccines and give them to you. But we have seen even some vaccines are not accessible, leave alone the COVID. Some vaccines are not accessible. So it has weakened our capacity to produce, vaccines or to grow the pharmaceutical capacity, and then we are waiting either to be served or to die collectively, which is real and unacceptable. So decolonization is now and has never been as important as it is today. Thank you.
Thank you, Dr. Danny Goto. So the floor is open to any panelist so that they could answer a few of your questions. I know Dr. Obed had many people asking him questions. I still remember, Josephine, you didn't ask your question. Yes, Josephine, you can go ahead and ask your question to anyone, including Dr. Obed.
Thank you very much, Dennis Kenya. Thank you very much, Dr. Obed Kavanda. Nice to see you again after a very long time. Thank you very much for all the presenters and the panelists, and for very interesting discussion. And I think the question that I was directing to Dr. Obed was, I think he was talking about alternative models to giving aid, alternative model. But also, I know, and I think this is quite also linked to what Dr. Danny Goto has just said. And I know we are all struggling and saying maybe the North is not doing this. But I also thought that what are we doing to look internally to be more effective with what we get? And actually, because even if the little aid comes to the smallest level, what incremental changes does this aid make? Because I think we need to grow our leadership internally within the local organizations to really see to it that when the money that we end up getting, we actually make incremental changes. What should be done? What are the tools? What are the models we can use to grow our leadership in local and medium organizations to see that whatever funding we get, we actually make a difference, and the development becomes incremental. Probably I'll talk about still the health sector because that's what I'm familiar to. And I'm saying, if I am giving this facility, what should we do? What models of leadership should we have that actually work to make sure that whatever money we bring makes incremental difference at the smallest level and we grow upwards? Otherwise, I don't believe that we should just, when this project ends, we look for money elsewhere, we change our models, we think something else just to get the money. To me, if you're really thinking about creating impact, I think that's not the best way to go. Let's grow leadership locally and we'll be a strong force to make a difference in our own society. Thank you. Over to you.
I have a radical view.
Thank you, Josephine.
I have a radical view.
Before you go, Doctor.
Briefly.
Before you go, please, Doctor, when you're answering this, Dr. Obed, remember the reaction from Thomas. I would really need to pick your mind on that. So, Dr. Danny, please, you were saying something.
I have a radical view. You see, the dependency that I was telling you about sort of corrupts the mind to always think outside. Let's assume Uganda one day comes and we do not have aid. Remember when we had a lockdown, a foreign expatriates disappeared, everyone ran away, and it was us. It was a wake-up call for Ugandans to start remembering that we need sanitizers. We need to make our own tents. We need to make our own food. We need to, I think it was a wake-up call. There is a way development and how it is channeled, particularly which we have not talked too much about, is the development that comes as loans. It has created some little bit of assumption that it will always be there. After all, you are picking debt to pay another time.
Yes.
So the radical view is the public must be engaged to demand better, be involved, and probably change leaders, because those who are there now, I don't think they can be changed. But how do we facilitate to have the right people in the leadership? And then we start to rethink development that is people-centered.
Thank you, Doctor.
Thank you, Dr. Danny. Can I come in, Dennis?
Yes, please.
Oh, sure, thank you. I want to thank Dr. Danny and everyone on the comments that have come up. And to Josephine, thank you so much. I can't see your face, but very nice to hear your voice once again after many years. And I hope you're doing well with PP Planned Parenthood. I must say that the question you raised is a very important one, and you seem to have already even devised a solution. Leadership development. I think that is core, and that goes with intentionality. I talked about the intentionality of building institutional capacity of organizations. One of the challenges we have is that most donors want to give funding for numbers, achieving numbers and targets and stuff like that. You all know and hear about this language a lot, but I think we must move away and demand space for building institutional capacity for organizations to grow. There's no way you're going to expect an organization to grow and be able to build its systems to manage resources without, allocating resources for internal capacity development. One of the issues I've raised with most of the donors is that there's no way you're going to expect people to gain impact and continue to sustainably support social change work without supporting their internal capacity development. And so I think whereas I appreciate your point of leadership development, it takes the intentionality of decolonizing the mentality of we must work with this partner to just meet numbers and targets, but work with an institution to grow its capacity. One of the goals of the fund that I'm talking about is we identify grassroots partners, but also work with them to handhold their capacity growth, to look at their institutional capacity building plans and work with them to have unrestricted funding, to define their goals, to define their growth, to define their scale, and take baby steps to grow as institutions. And I think that is core if we are to see changes. Now, to the point of Thomas, he raised a very good point of the rich international NGOs, but also the professional NGOs who compete and have influence on the African continent. I think this is very key. I must say one of the big challenges we are trying to fight with the fund is that we must move away from silos. We must move away from competition. Why should I compete with Dr. Danny? Why should I compete with this? And why should I compete with someone else in Zambia? I think as Africans, we must wake up and know that we are all, fighting one elephant, and we must work together. We must move away from, working in silos and competing for resources, but working together as consortiums. That's why through this fund, we are not looking at people, writing proposals and competing and saying, hey, you lost the fund because this one got the fund, because they must be ways of saying Zambia has this number of NGOs and how do we work with them, prioritize funding that goes to specific actors, because people waste time. Look at how much time people spend writing proposals, and only what you are told is, hey, we regret that you never went through, and sometimes even they're going to use your proposal for other things. So I think it's a point of working together and challenging the narratives of competition, but working together collaboratively to cause social change. Thank you.
Thank you. I see two hands up. That is Makecha and Edward. Can I start with Edward? Edward, you have the floor. Edward?
Yes. Thank you. I would like also to appreciate the insights that we have had. Mine is also to add on when it comes to decolonization and the insights that have been brought out. I think it all lies squarely on leadership and the way we prioritize. It is very important that we look at our priorities, and I would say that it's important to have heavy investment in research, and that is through science and technology, so that we build the local capacity. Because at the end of the day, you're having, like Dr. Bed has pointed out, you're having our best brains right all those and getting disappointments at the end of the day, because reality is they have to earn, they have to feed their families. And government involvement where you have these brains building for our challenges. When you look at the vaccine, when you look at treatment of COVID, and they are facilitated to drive because it causes issues, and that can only happen when so that we get solutions. But when you look at decolonization and you don't talk about research in science and technology, we shall be wiped away. So it should be a process and a deliberate effort to invest. Thank you.
Sorry, Edward, we can hardly hear you now. But I think you made the point, Edward. Can we have coach?
Yes, thank you, Dennis. Mine is a general comment to the whole discussion, and I'm going to base on 4 things. One, the aspect of decolonization should also be supplemented by a discussion around what exactly our internal governments are doing in relation to provision of aid. For example, in Uganda, many people have recently pointed fingers at private health facilities, including a number of NGOs, but no one is actually talking about what should the government do to actually help these private health facilities. The second part is that there seems to be a disconnect between the NGOs and the local communities. An NGO wakes up in the morning and goes to a society or a district like Koboko, and they want to provide a service. And yet the community actually doesn't know what is happening. So at the end of the day, you actually find that the issues around decolonizing cannot actually go away because the NGO is on their own and the local community is also on their own. But finally, if you look at the issues around the NGOs, and it's something which I've put on the comments, that an NGO is basically looking at, is my 70% of my staff salary covered? And if it's covered, then the issue of around decolonization becomes another issue. Thank you very much.
Thank you, Jacob. Before the panelists can come in, there are also some things I would really want you to react to in the question box. Dr. Neka says, wait, doctor. Dr. Neka says, I think we need to more intention about harnessing our collective power and thinking behind the geographical boundaries we have in Africa. What is the role of social entrepreneurship in helping to drive the information change we need? Then also we have Josephine, who says, thanks for the great discussion. Looking forward to more engagement as we seek to find meaningful impact and development. I have, question to the panelists, where is the place for much despised Africa's indigenous medicines in the decolonization discourse? And then we have Hamim. Okay, yeah. So the panelists, please briefly, as you make reactions, I think it is also time for you to make your concluding remarks so that we can wrap this up. Thank you. I begin with Dr. Bed, I think.
Thank you for that opportunity, Bukenya, and for all the members who are still hanging in. I know we are already 13 minutes late to end this presentation, but I want to say 2 things. Number one, to Dr. Neka's point, I think the issue of collective power and going beyond the geographical boundaries is very key, very important, especially when we are seeing, changes going on the continent, and yet we are facing the same challenges. We need best practices to be shared across borders. We must begin to think beyond just our in-held countries, small countries, which, try keep us within the localization of our best practices. We need to get out. We need to learn more what is going on anywhere else beyond our countries. So I totally agree with you. We need this collective power by working together. I said in my talk, we are not going to talk about decolonizing global aid as Africans if we don't work together as Africans. And I think this is a huge point for us as Africans as we try to work together to challenge some of these systemic narratives that have been created by colonial situations. I think as I end today, I think the point that seems to be coming out strong is that there is need for decolonizing aid, but the point is, how do we go about this? And is this the time? I do want to say that I think the time is now. We cannot keep quiet. We cannot keep watching. And I think we must do something about this together. We must have collective, work on these efforts. We must avoid silos. We must work together more and be able to challenge, not only the bilaterals and the international NGOs and hold them accountable on how they are, directing aid, but we must actually be in the driving seat by demanding changes in the systemic way of how aid is being managed. And we must take control of who defines goals of these programs, who defines goals of this funding, and who defines how indicators are going to be set, because that's the only way. And also focusing much on research. Evidence-based, we are not going to change these things if we don't have evidence-based data. We need research, and we must have our local experts to support some of these changes. Thank you so much.
Thank you so much, Doctor. So we go to Dr. Danny Goto, and before you again leave, Doctor, I would want you to conclude by giving people an highlight or a sneak peek of what is yet to come, as Ravi did. Over.
Okay, thank you so much. Recently, I wrote an article in papers in rebutting Mr. Museveni's assertion where he said that the African kings were wearing the animal skin when the European colonizers came to take our people for slavery in the Americas. Yes, we've been on this issue for self-determination for quite some time, but we must recognize that we have inherent internal weaknesses. The weaknesses of cohesion, having a clear strategy, and working towards that particular strategy. We quickly get swayed by so many external forces, either money or mere ideological disorientation. And that touches core to what people talked about, the aspect of leadership. Now, someone talked about social entrepreneurship having a space. Yes, it has a space, but it is not a panacea. There's sometimes the buzzwords come from all sorts of places and people think that they will define the problems totally. No, social entrepreneurship is also a contributor, but it could not fix all the needs or challenges of the people. I want to also conclude by saying, someone talked of indigenous medicine. Yes, we have a series of conversations on the coming webinars that will talk about indigenous medicine in research and human resources for health and how we can use that. So I think that will be answered there. But I want to end on this note by saying that this is a wake-up call for all human beings, wherever they are, in their sheds, that something is not right. We need to start looking at ourselves as a collective. For the Africans on this platform, we need to have the right solidarity, partner with those who think like us and challenge, but we need to grow internal capacities in whatever ways we can. Then we need to fix the ideological disorientation, especially within the leadership. Take an example of corruption. People steal money out of Africa, bank it in European banks and American banks. And this is at the top of leadership. We all know this, but we've let it happen. Then we complain that the people giving loans are taking us for a ride. Then, of course, we need to point out those that we think are not giving us the right deal, whether they are international NGOs, whether they are development actors. But that can only happen when we are less vulnerable. When we're collecting information for this paper, I met a number of agencies in Uganda, USAID, FCDO, big agencies that are investing. They are interested. For instance, the Americans are talking of, growing, self-reliance. Of course, the Biden administration is changing it. That's what they're telling me. But they were trying to have conversations of how can we make countries self-reliant, and they're approaching it from the side of building leadership and accountability and creating strong civil society. But I think we need to bring the voice, and our voice must be strong and it must be heard, so that we also recognize that we are there and we are interested in these discourses. So that's why I need to thank all of you who have come on this webinar and are interested in this conversation. This is not the last. We were having a series of conversations together with our partners, Kampala Initiative, People's Health Movement, and the coming series are going to look at the human resources for health and how we can have a conversation around decolonizing the human resources for health. It is broader. We are looking at how education of health workers, brain drain, if you want to call it that. Who do we train health worker for? Is it for the Ugandan system? We are talking about the role of indigenous knowledge and indigenous medicine in the discourse of preparing health workers, language, and issues like that. Then we're also looking at the aspect of research. The subject of research and health systems policy is skewed. It is driven by academia, which academia is in cahoots with the colonizers or the colonialists in that regard. So we want to have a conversation on that aspect. And then lastly, we need to interrogate the health laws, the public health laws that we are subjecting ourselves to, especially in the controls of this epidemic. COVID has given us a wake-up call to examine, for instance, for Uganda's case, our public health laws, or the laws that we have in the country, and how we can use them to protect ourselves, but also to use them to fight epidemics. So I want to end at that and thank everyone for joining us. A report will be produced from all these series of webinars, and hopefully you've left your contact, and we shall disseminate it for your input. Of course, probably in the coming series, we'll discuss more on what next after we've had all the webinars. Thank you so much. I end it at that.
Thank you so much, Dr. Danny, and everyone on this call. At this juncture, we have officially closed this webinar, and my apologies to many of you who wanted to make contributions, but because of time, we have eaten almost 30 minutes into the stoppage time. So next time, we shall try to manage this better. I have had communication from Naume. She says, sorry, she failed with her internet connection, but she hopes to be with us next time. Otherwise, from me and my team, see you once again. Bye for now.
Bye, thank you.